So today we're going to talk about seizures. I'm going to try to kind of fit a lot into 40 minutes. Um, for those of you that have seen me talk before, it'll be a lot of the same stuff, but there's also some new stuff I put in at the end just because there's been some new developments in the last few years epilepsy-wise. So just going to start off just because it'll come up later, but just a quick reminder of the two different subtypes of 15q duplication syndrome. There's the isodiecentric, which is the extra chromosome, so 47 instead of 46, with two extra copies. And the interstitial duplications where you have the same kind of 46 chromosomes as everyone else, but there's an extra copy in one of the chromosomes, and then rarely you can have triplication, which is two extra copies, but it's still just in those 46 chromosomes. And as we'll see, the kind of the more copies you have, the more severe the symptoms of the syndrome. And then just kind of going over the just real quick, the neurological and psychological manifestations. With 15q duplication syndrome, it's mostly neurologic / psychological. We see epilepsy, sleep problems, developmental delays, autism, anxiety / tough behaviors, and then even the GI dysfunction and the ophthalmologic issues. It's really due to due to low tone, that kind of low tone that you see in the arms and the legs. In the trunk, you also see it in the smooth muscle in the GI tract and in the muscles that help move the eyes around. So it kind of all leads back to the nervous system. And then, so seizure types and syndromes, just to go over a couple of quick definitions, because it's confusing, and it's confusing for us. They change the definitions and they change the titles of things every few years, so it's hard to keep up. But even epilepsy, they kind of change the definition. So it's defined as two or more unprovoked seizures. Unprovoked meaning that it wasn't because you were hit in the head or had meningitis, it just kind of had seizures. So two or more seizures, or one unprovoked seizure, but with kind of abnormal spikes on your EEG. So when a lot of people will say like, oh, we have seizures or seizure disorder, but not epilepsy. But if you have, and just having two seizures is epilepsy. So whether it's 2 or 30 a day, it's still epilepsy. Seizure types describe the actual type of seizure that you're having, and we'll talk about the different ones in a little bit. And then the other one that I think can be confusing is epilepsy syndromes. So an epilepsy syndrome is a combination of seizure types, specific findings on an EEG, and then also the level of kind of cognition that people have, whether they're delayed or they're on track. So there's a couple of those that will pop up, that we see in 15q duplication. So just kind of knowing those names is helpful to make it a little bit less confusing when they pop up. Oops. Oh, where did I go? Okay. And just a word of warning, I think it's probably been around forever, but I think I finally found that designer feature on the PowerPoint. So maybe gone a little overboard with some of the slides later, but it was fun. So the two different, the two classes of seizure type, there's focal, or it used to be called partial. And that's when a seizure comes from one part of the brain. So, it could be like, the right frontal, the left temporal, the back of the brain. And the symptoms you get depend on what part of the brain it's in, whether it's in the part that moves your arm and legs and face, or the part that involves speech. So depending where it is, it'll look different. And then generalized seizures are where the whole brain is involved, and it's often the connections from the kind of the outer part of the brain where you have your seizures, and the kind of the relay centers in the middle. And so when you look at an EEG, the whole brain will be involved at once. So without knowing how to read EEGs, just kind of the point is, like these 4 sets of lines are kind of 4 quadrants of the brain. And you can see on this side for the focal, there's abnormalities just in that one part of the brain, whereas in the generalized, it's kind of like every piece of the brain is having the abnormal spikes. So that's focal versus generalized. And then within generalized, there's several different categories. The ones that we see in kids who are either typically developing or have delays are generalized tonic-clonic, which is what we all kind of think about. Eyes roll back, everything's shaking. They used to be in the long time ago called grand malls, but those are tonic-clonic seizures. Myoclonic, which is kind of a quick twitch. So if I bore you enough that you start drifting off, and you kind of get that quick, you kind of feel like you're falling and you twitch yourself awake, that's myoclonus. For us to do that in sleep is totally normal, but when people do it wide awake in the middle of the day, that's a myoclonic seizure. And then absence is kind of what we think like a staring spell. So, you'll be doing something, you just kind of stop and pause. There's typical and atypical. What we see in kids with Dup15 is more atypical absence. So the seizures can be longer. Instead of just a couple of seconds of blanking out, it can be 30, 45 seconds. And they're not often, often they're not totally out. They're just kind of mostly, so they can respond a little bit, but very atypical. And then kind of the two harder ones to treat, tonic seizures and spasms. They kind of look the same on EEG. You'll have kind of the EEG background that kind of flattens out for a little bit. So tonic, what'll happen is it'll be kind of a quick, not quite a twitch, but like you'll see that head or trunk go forward, and then it just kind of stays stuck for several seconds. And then a spasm is when everything kind of like head, arms, trunk kind of flexes forward, but just for a second or 2 seconds tops, and then stops. They often come in clusters. You can have those as an infant. They're called infantile spasms, and those are pretty common in Dup15. But you can also get them later in life. And they're still called spasms, but we just call them epileptic spasms. The infantile part just refers to the age that you have them. And then, so those are the main types. And then so epilepsy in 15q duplication syndrome in general. So what we think of, like when we talk about the focal and generalized, epilepsy is, for kids with Dup15, it's more focal or multifocal. So it's one part, but really much more often multiple areas that can have seizures. So, people will have seizures that look focal. They'll have like just the eyes to the side, the head to the side, some arm like posturing or shaking. Those are kind of the common focal seizure looks. And that's often how seizures start. But for a pretty good size subset of kids with epilepsy, it'll what we call secondarily generalized. So those little spots that can cause seizures will kind of blend together, and you get a more generalized syndrome. We call it secondarily generalized. So it kind of starts off focal, but then then the whole brain gets involved, and that will in this syndrome will lead to what we call like a Lennox-Gastaut type of epilepsy, which I'll talk about later. That can be hard to treat. So with so there's really quite a spectrum with epilepsy. And just looking at an MRI, this is one of our kids, just to kind of point out, MRIs are usually don't see a lot, but in some we do see some abnormalities that shows us that there probably will be focal seizures coming from one area. And again, you don't have to read MRIs to know, but this is kind of a nice kind of like good sized what we call hippocampus, and over here it's like much smaller, it's brighter, and we see that in a lot of kids. We see these little subtle changes on MRI, but we know those are probably areas where seizures are coming from. This was from the survey we did back in like 2009, a while ago, but it just shows that with Dup15q you can have all these different types. So pretty much all we talked about, this is the focal seizures, but then all the different types of generalized seizures. So it really is quite a mix of the seizure types that you can see. In other syndromes, there's certain seizure types that you just don't see, like in Angelman syndrome where you don't see tonic or spasms, but in Dup15 you really have the full array of seizure types. So looking at by subtype, for people with isodiecentric chromosome 15q duplications, there's prevalence of epilepsy about 50 to 60%. We think in the survey that we did a while back, it was 63% with 26% having spasms. That's probably a little bit inflated. With any of these kind of surveys you do, you're going to get more people responding that had seizures and didn't. But when you look at the literature as a whole and just looking at our clinic population, the 50 to 60 feels about right. And with interstitial duplications, there's not a lot of data. In that survey, we had 16%. The first, I don't know, I can't remember, it was like 100 kids we saw at Mass General. It was about 18%. And then in the study that Larry Ryder did that we helped with, it was 1 out of 13, so more like 8%. That's probably the most accurate, just because of the way the sample was picked. And that seems right with interstitial duplications, probably in the neighborhood of like 8%, 10%, somewhere in that neighborhood. And the triplications, we just don't know yet. We're kind of collecting data on those kids. We've seen probably 10 by now. And so with triplications, the interstitial triplications, you have 4 copies, similar to the isodiecentric kids, but you also have 46 chromosomes versus 47, similar to the interstitial duplication kids. So, and what we're seeing is it's kind of somewhere in the middle. But that's something that we really want to look at further. But it's its own kind of thing. But it probably does kind of the spectrum of the severity does kind of fall somewhere in between the two overall. But that's something that we definitely want to look at more. And then by age, infantile spasms are when you're an infant. So those begin at less than a year of age. And then typically, kids that have spasms, or even kids without spasms that go on to develop like a Lennox-Gastaut syndrome, it's usually 2 or 3 years. I think the average age for Lennox-Gastaut to start is like 26 months or 28 months, something like that. But in Dup15q, what we typically see is it's more like 7 to 9 years. We've seen it start as late as 10 or 11 years. So as kids get older, these more difficult seizures can present later, which is hard because you don't know if it's coming or not. A lot of it, as far as it's impossible to predict, but kind of the developmental tract kind of gives a clue. Kids who are nonverbal and hit their motor stones really late, they're at more risk for developing those, and definitely it won't be all of them, but they're just at a higher risk than those who are verbal and hit their motor milestones earlier. But that's one thing that can be really confusing about Dup15 epilepsy specifically, is that the Lennox-Gastaut type epilepsy typically develops later, which is just not the norm for Lennox-Gastaut. And then for those who have spasms and then get focal seizures, they'll often do not experience spasms, and then their first seizures are beyond the spasms period. They can start in early childhood or puberty. Those are kind of the two hot spots to start with focal seizures. And people that have just focal seizure, they usually much a lot easier to control than the ones that have the more Lennox-Gastaut type. And then looking at the epilepsy syndromes, there's 3 of them that really kind of seem to fit in Dup15. West syndrome is kind of the official name, but it's basically infantile spasm. So it's a combination. And again, it's seizure types, it's EEG findings, and then it's developmental level. So it's in kids who are developmentally delayed. The spasms typically start less than a year of age, and again, it's those kind of quick, like kind of crunching, kind of like stiffening and kind of moving forward type of motions. And then a classic EEG finding called hypsarrhythmia. And again, you don't have to read EEGs it's just very chaotic. It's very high voltage. It all kind of runs together. But the nice thing is if you treat it early and you treat it with the right meds, you can actually, resolve that abnormal EEG pattern. And then that really helps with development a lot. And this is just what a spasm looks like. You have the abnormal background, it kind of flattens out like I talked about before, and then goes back. And during that little 1.5 second of flattening, that's when you see the kind of the head and trunk go forward. And this is what it looks like in an older kid. Again, it's you don't have to know exactly what these are, but just showing that the background doesn't show the hypsarrhythmia, but you still have that little flattening. Just to kind of show you that like it also happens in older kids, but that hypsarrhythmia is really just for the infants. And then so Lennox-Gastaut, I've already said it like 10 times probably, but people with Dup15 that don't have just focal seizures, they have the bigger spectrum. Pretty much all meet criteria for Lennox-Gastaut, which is mixed seizure types, kind of classically atonic, tonic, or atypical absence. But you can also have myoclonic, the tonic-clonic, in the focal. And then also spasms, as we talked about. Dup15 is one of those syndromes where spasms are more common. There's a few like tuberous sclerosis and others, but this is one of them. And the most common cause for spasms is what we call dysplasias. So little parts of the brain that don't quite develop right. And like anyone can have them, but in Dup15, there's, when they've looked at kind of brain tissue on the microscope, there's these little kind of mini dysplasias like all over the brain. So you don't really see them on MRI, but we know they're there, and just kind of their presence is why there's a higher spasm rate than in just the general epilepsy world. So that's typically Lennox-Gastaut, and the main thing with Lennox-Gastaut is just like kind of what we call it like less than 3 hertz spike in waves. So you get these kind of a spike and a wave afterwards, and there's all these green lines are 1 second each. So there's kind of 1 or 2 per second, and this is also just kind of these kind of constant spikes. Kind of fits the criteria for non-convulsive status epilepticus, which is you're not kind of physically you don't see seizure activity clinically. It's just kind of there on the EEG in the background. And what we see in the kids themselves that have these EEGs is just kind of a quick regression in skills. So whether it's balance, coordination, if they're verbal, they're less verbal. So and it usually comes on pretty quick. And when that happens, we want to treat it as soon as we can and to try to reverse that. And we'll talk about the treatments later, but kind of this non-convulsive status picture is not uncommon in Lennox-Gastaut. And then CWS, so technically CSWS is you start off with typical development and then it kicks in, but it's a CSWS type of epilepsy. And this is where, like I said before, the names keep changing. It was ESES, then it was CSWS for years, and now it's DEESWAS. So it's hard to keep track, but the CSWS stands for continuous spike wave of sleep. And what happens is, you may not even see clinical seizures, but you start getting, your sleep at night when you fall asleep, your EEG just starts to fill up with spikes. And so not only does that just kind of disrupt the EEG itself, but it really disrupts the sleep patterns. And then with that, you start seeing kind of a regression with skills or just a failure to gain new skills. And then those two together kind of give you this CSWS picture, which again, is treatable. So it's important to kind of catch that early if the symptoms are there. And then that's kind of what it looks like in sleep. It's just kind of these constant spikes. And then this is a slide I just kind of threw in. This is a very specific EEG pattern in Dup15q. Just, we'll talk in a minute about the others, but there's a few different EEG patterns that are really kind of specific to this syndrome that can, that definitely help with diagnosis, but also, being able to kind of treat these and minimize them in sleep really helps with the developmental process. And then just kind of thinking about the EEG findings, so for the kids with the Lennox-Gastaut variant, you have those big bursts of spike and wave. You have the CSWS kind of pattern that we just looked at. And the other thing that I'm sure you've already heard about this this meeting, especially in regards to the trials, the EEG shows what we call excessive beta activity. And when you look at an EEG, you see like this is all these darker lines are 1 second. And you look at this this little kind of low, like you can see 1, 2, 3, 4, 5, 6. So there's 16 to 18 of those. And typically you only see that when kids are on, Valium or clobazam or some kind of benzo. But the fact that this occurs naturally in kids with Dup15 tells us that there's probably some abnormality in it's the chemical in the brain called GABA, and there's receptors for that chemical. There's genes for making receptors for that chemical that are duplicated in 15q duplication syndrome. So, clinically, what does that mean? That's what we're still trying to kind of wrap our heads around. But also, that was kind of the thing that kind of led towards the trial that's just starting. Knowing that there's all this kind of excess GABA activity in the brain, would kind of controlling that and normalizing the EEG, would that help the kind of treat the symptoms of the syndrome? And the beta activity itself isn't a problem, it's just there. But the fact that it's there tells us that there's something else going on. So it's more of a marker of something else going on in the background. And if that goes away, it probably tells us that whatever's going on in the background has been at least normalized somewhat. And what are the effects that'll have on just the whole clinical picture. And we don't know, but it's exciting to think that there could be some real benefit to it. And then, okay, so treatment. So this is so I was talking about the PowerPoint that just kind of gave me these brains and DNA, which I thought was kind of fun. So I think this is one of the most important slides because it's one of the biggest things that we always focus on. And like anyone that that sees us, whenever you call or send a message, always the first thing we say is, how are you sleeping? How are you pooping? Like that kind of stuff. So, epilepsy in general is associated with what we call comorbidities. That just means other things that come along with having epilepsy. And so we see that in anyone that has seizures, but in kids with neurogenetic syndromes and epilepsy, it's a lot more significant. And the big things that really can worsen seizures are poor sleep, constipation, reflux, even anxiety. But really, it's the sleep and the GI stuff that can really kind of increase seizures pretty significantly. So sometimes when someone's having a seizure flare, we'll give them a sleep med or lots of Miralax or Senna, and their seizures will decrease even without changing their seizure meds. So the one of the best things you can do to help prevent seizures, but also help fix them when they really kind of increase, is to treat everything else. Because when kind of everything from the neck down is working better, you're going to have less seizures, and it just makes kind of our job easier to treat the seizures if everything else is working well. So that's, before we even get into the kind of seizure specific treatments, I think this is probably one of the most important things to really emphasize, is that the better, because it's easy to think, well, the seizures are the important things, so we're going to focus on that. We'll worry about sleep later. We'll worry about constipation later. But it's things like bad sleep and constipation can really worsen the seizures. So it's important to kind of treat everything at once if possible. And it's interesting, like with looking at the things that can worsen the seizures. Sometimes you'll have constipation or reflux, and then those symptoms worsen your sleep, and then now you've got that plus sleep, and then that's really kind of a recipe for a seizure increase. So that's one of the most important things we can do, is really kind of work on the rest of the body too. And then more the fun little icons there. So there's three main ways to treat. Some medications is kind of the standard, that's always, first thing we do, but then diet therapy and also surgical options are available. So starting with medications, so these are the medicines that really treat kind of focal or tonic-clonic seizures, but aren't great for head drops or absent seizures or spasms or tonic seizures. So these aren't used too much, just because we see so much more the Lennox-Gastaut versus the plain focal seizures. But so these medicines can all be effective in those seizures, but it's really just if you clearly have focal and tonic-clonic and nothing else. These can be helpful. We do use a lot of gabapentin, not as much Lyrica, but it's very similar. But we use gabapentin a lot for sleep. So even though it's not great for seizures, it's not going to make your seizures worse, and it can be a really good sleep medication. So we do use this one a lot. And I know that Ed Cook is a really big fan of the Jaguar for some of the psychiatric issues that are associated with Dup15, specifically kind of a bipolar type syndrome that teens can get. So even if they're not being used for seizures, at least a few of these medicines can have other really important uses in the syndrome. And then looking at what we call broad spectrum medicines, are the ones that will treat all kinds of seizures. So they'll treat the tonic-clonic and the focal, but also the absence and the head drops and the whole bit. And so like when we were starting the clinic, this is kind of what we had. We had the ones on the other page, and then we had these, the succinimide, an old medicine that's good for absence, but that's kind of its main use. Klonopin and some of the older benzos are great for rescue, but not so great for everyday use. Depakote has a lot of side effects. Felbutol requires a ton of blood. So we had, kind of these other ones that were kind of the main seizures, and then they all work really well. But in the last, 10 plus years, a whole bunch of new broad spectrum medicines have come out. So Onfi, actually, we've been using Onfi a lot longer than this. We used to get it from Canada before it was approved in the US in about 2010. But there's a pharmacy in Vancouver that would kind of ship it across the border. It sounds sketchy, but it was totally legal. And that stopped once it was approved in the US. But these first three we actually use quite a bit. They're very helpful for the seizure types we see with Dup15. Clobazam or Onfi and refinamide or Banzel are actually FDA approved for Lennox-Gastaut syndrome. Vimpat is not, but it you know, it really does help with those seizure types as well. One of them's off the market. Aptium is, so if you go back go back here. So carbamazepine or Tegretol is an older medicine. Predates me for sure. It's the newer version of that is Trileptal. So Trileptal is it's a little bit safer, a little bit better tolerated. It's not as good for the psychiatric symptoms as Tegretol is, though. But from a seizure standpoint, it's a little bit easier to use. And then the newer version of that is Aptium. So again, it's not really a broad spectrum, so we don't use it too much. But for focal seizures, it can be really helpful. And then along with those three, Fycompa or Perampanel has also been a medicine that we've had some good luck with. It's a novel mechanism, so it's the first medicine instead of like most of these medicines work by kind of slowing down these the channels in the brain cells that kind of let in, you know, potassium and sodium and calcium, and by doing that, it kind of stabilizes the brain cells and makes it harder to you know, kind of send off too much extra activity. But the other way that some of the medicines work are it kind of enhances the chemical GABA that we talked about. That's kind of the main chemical in the brain that kind of slows things down. Perampanel's the only medicine so far that works on the chemicals that kind of ramp things up, and it kind of quiets that. So it's kind of you know, it's nice to have another medicine that works by a different mechanism. So that's helpful. And a lot of these, nice thing about these medicines, they don't really require blood. So Onfi, Banzel, Vimpat, Fycompa, you know, we're not checking blood levels like we are with a lot of the older medicines. Briviact is one that's been really helpful to us. It's so Keppra is levetiracetam. This is brivaracetam. It's like the next generation. It's pretty much the same as Keppra, except that there's one receptor that it doesn't work at that Keppra does. And the thought is that one receptor is the one that makes people cranky. So it's kind of like Keppra with much less crankiness, which has been great. So people that have been on Keppra that have been cranky had to come off it for that. Now we can try the Briviact. Ideally, we would do it before Keppra, but insurances won't pay for it unless you've failed Keppra. So we're still using Keppra first. But if there's crankiness, instead of just giving up, we can just switch it straight to Briviact, which is really you know, been helpful. So a lot of people that their seizures improved, but they were irritable, cranky. You know, we've been able to just switch the Keppra to Briviact, and you can do that like overnight, pretty much, which is great because they're so similar. But it's kind of a newer Keppra, which has been really good. And then one that we've actually been using a lot because we've seen some pretty good results is Epidiolex. So it's a cannabinoid. It's basically medicine made from marijuana. It's more or less marijuana in sesame oil, but they take out the THC. So the THC is the part that gets you high. The cannabinoids are the part that don't. And that's what's in the medicine. And it's really kind of safe and mild enough that it's no longer a controlled medicine. So when you go to the pharmacy to pick up Onfi, you have to give your license and all this other stuff, like you're a drug dealer almost. And then, but like for the medicine that actually contains marijuana, you don't, because it's just with the THC out, it's really safe. But it's you know, it does have you know, they're looking at it now for autism for behavioral behavioral treatment, but so it does for some people has a calming effect, which is really a nice kind of bonus. But it's been really good for seizures. And again, you know, all these medicines and trials, you know, they're about 40% effective. In Dup15, we've been finding that most medicines are much less than 40% effective. But the Epidiolex, we actually have seen, I don't know if it's quite 40%, but you know, it may be close to that if we go back and look. But it's, you know, we actually have had kids that have failed several medicines that have done well in the Epidiolex. So that's been a nice addition. And then since then, so just in the last year or so, 2 new medicines have come out, fenfluramine or Fintepla, and then cenobamate or Xcopri. So Xcopri is kind of like Felbutol, which is one of those kind of older broad spectrums that came out in the 90s. And when it came out, there were several deaths early on, liver failure or aplastic anemia, where there's kind of all your you know, red blood cell, white blood cells that just kind of like just drop dramatically. They were all in adults, not in kids. So Felbutol is still used. You just have to use it. Yeah, you have to, kind of go up slowly and just be very cautious. Get labs weekly for a while, then monthly, and then every couple months. But Xcarpi is kind of a newer version of that, and it has a little different. It does a little bit more than the Felbutol did. It improves GABA, but also blocks sodium channels. So it has a couple ways it works. So it's been a nice medicine that's been really effective for a lot of kids, but also unlike Felbutol, we don't require all those blood draws, which makes it so much nicer. And we kind of have to use what we have to use, but ideally with especially kids with Dup15, like we really try to use medicines that don't require blood draws if we can. If we have to, we have to, but we do know how painful that is. And so like I always, try to use the ones that don't require that to start. And then Fintepla, so pretty much every med that's come out has had a 40% success rate. That's just kind of been where they've fallen, whether it's treating focal seizures in adults or Lennox-Gastaut, or so kind of what it was trying to treat. If you're 40% for Lennox-Gastaut versus 40% for focal seizures, that's the one that's treating Lennox-Gastaut is probably a better medicine. But in kids with Lennox-Gastaut or Dravet syndrome, both really difficult seizure syndromes to treat, it had about a 70% success rate in trials. So the first medicine that's come out that's really been kind of above and beyond what's already on the market. It's easy to use. There's no labs. The pain in the butt is you do an echocardiogram every 6 months, so an ultrasound of the heart. There's because it's a serotonin, it enhances serotonin. There's some risk of cardiac, and it was half of the diet drug Fen-Phen in the 80s. But it was that was causing lots of heart problems in people, but they were people were taking it so was adults taking it for weight loss, so they didn't have the healthiest hearts to begin with, and then it was the combination of the two that was really tough. In the trials, there's been little to no cardiac risk, so it's one of those things where the FDA is being a little extra cautious, and caution is not a bad thing. So they're a little bit of a pain, but other than the echoes, it's there's really not a lot of monitoring. We've had, again, we've probably used it on maybe a half a dozen kids, but we've seen some really good results so far. So it's crazy to think that when we started our clinic, like we had these medicines, with a couple not being super helpful and a couple being like really high maintenance in terms of getting a ton of blood, to 10 years later having these, and now with these two meds, the medications have come a long way. And even we've had a couple of kids that do 15 that really not much has helped. The Fintepla has been really good for. So and there's always new medicines coming out. Just looking at what's happened since 2010, that obviously the clinical trials for the more kind of Dup15 specific medications are, those are the ones that will hopefully kind of get to the root of the cause. But even just treating the symptoms, there's new drugs coming out all the time, which is really exciting. And this is just kind of, I don't know if this is confusing or not, but when we did our seizure survey, and we've kind of seen it as well, just clinically over the years, for kids with spasms, ACTH versus vigabatrin, ACTH has had a much higher success rate in kids with Dup15. In the general spasm population, they're pretty even. And in kids with tuberous sclerosis, actually vigabatrin is better, but for Dup15, it seems to be the opposite. It seems like the steroids are the better choice. And part of it, we talked about the abnormal GABA transmission with causing that extra activity on the EEG. Vigabatrin kind of works with that chemical, so that may be why it doesn't work as well for these kids. But the steroids tend to work really well, which is good to know. So looking at treatment of so that that's kind of looking at the treatments for the spasms, looking at the CSWS and non-convulsive status. The kind of the daily meds that you're on, the Keppras, the Onfis, the Finteplas, those are what are hopefully going to really kind of prevent the day-to-day seizures and also prevent the EEG from really becoming full spikes. But when it does become full of spikes like that, and the daily meds aren't really getting it done, there's a couple of ways to try to get that better quickly. So you want to do that, one, to just get better quickly and get your development kind of back on track, but also by doing that, you kind of buy yourself more time to change the other meds and get those squared away. So number one is Valium or diazepam. It's typically the treatment of choice for CSWS. What we do is we bring kids into the hospital, when their EEG is not so bad during the day, but like just full of spikes at night. We bring them in, we get the overnight EEG to kind of confirm that's what's going on. Then the next night, give them a big dose of Valium. It's usually like 1 mg per kilo, which like would knock us out for days, but that doesn't even make these kids fall asleep. And then if it works, they go home on a smaller dose, but still a big dose at night. And ideally that, that kind of keeps that pattern away. If it's if it's an alcohol status, and I kind of use that loosely, if it's during the day you're seeing a lot of spikes, or you're just seeing a ton of seizures that the regular medicines just aren't controlling, the diazepam can be helpful just to really kind of get that number of seizures down quickly. And again, like just for overall safety and well-being, but then also buys you time to kind of adjust the other medicines in the background. Valium, it generally works well in the epilepsy population. It works really well for kids with Angelman. It doesn't always work as well for kids with Dup15, but what does work well in my experience at least, is the steroid. Same thing as that we use for the spasms. We can use it to really kind of quiet down these EEG patterns. So we usually start with like 60 or 80 milligrams a day of prednisone or prednisolone, and then do that for a week or 10 days, and then kind of down from there, like 50, 40, 30, 10. But and if kids are real little, then it's not the full 60 we do like per kilogram. And for kids that are really treatment resistant and the steroids kind of help a little bit, but not so much, we can even bring them into the hospital and do 3 or 5 days with IV steroids, and then with the kind of a by mouth taper afterwards. Again, like anything, it doesn't work for everybody, but it's that's really helped with a lot of kids who were really just like nothing was quieting things down. But I don't know if it's just because other measures don't work so much, so it seems like it works better, or if the steroids really do work better for kids with Dup15 than for the general epilepsy population. But it just kind of, the experience we've had over the years is that they're very helpful. And again, they're not a long-term solution; they're a very short-term solution, but they can work well in that short term to kind of make things better quick, and then hopefully maybe make other changes to keep things better once they do improve. And then diet therapy. It's one of the big things to think about. And with diet therapy, even before you start a diet for epilepsy, is adequate nutrition. And kids don't get adequate calories for a lot of reasons. Either they have GI issues, they're not absorbing it, or they're intolerant to certain foods, or it can be more of an autism thing where they just have like texture or taste aversions, and they just won't eat certain things. So we've had kids where they've really been losing weight, struggling with seizures. They've gotten a G-tube kind of in preparation to do they said, kind of said, before we do the ketogenic diet, let's get a G-tube because we're going to need, to really do that. Put the G-tube in, they get the right amount of calories, and they haven't even had to go on diet therapy just because, that's, inadequate calories and weight loss is a big seizure trigger. So sometimes just fixing that alone before you even switch the diet around can be helpful. And then thinking about dietary therapy itself, the ketogenic diet's been around since the 20s, but goes back to ancient Greece or Rome. What they used to do was starve people, and notice that if they didn't eat for 3 weeks, their seizures would get better. So that's really not a practical solution for people these days. But what the ketogenic diet was developed to do was, because when you're starving, you just break down the fat on your body because you're not getting anything, you're not eating anything. So the ketogenic diet was made to kind of trick your brain into thinking you were starving and just burning fat instead of proteins, carbohydrates, that kind of thing. The ketogenic diet was the original diet, but since then there's low glycemic, which is what we use a lot, but also there's Atkins or modified Atkins and probably some others. But ketogenic was the kind of the original, and then I said we use a lot of low glycemic. And then the question is, like, how does it work? Why does it work? And we don't really know. But what we do know is that it does a lot of things, and we think they're all kind of involved. Definitely, and that's kind of the thing behind the low glycemic index, was keeping your blood sugar levels and your blood insulin levels nice and low and stable. We also think there's some benefit to having ketones in the blood, the brain kind of utilizing the fat. And what's been looked at more recently is changes in the microbiome. So basically the kind of the bacteria living in your gut. When you switch your diet and you're really kind of getting more fat than anything else, it does change kind of the bacteria that you have in there. And there's some thought that change is helpful to the brain. And then just I won't go into too much detail, but the kind of looking at the differences between ketogenic and low glycemic. Ketogenic is 90% fat, less than 10 grams of carbs per day. So kind of to the point where you have to change your toothpaste and like all that kind of little details just to avoid getting any grams of carbs. For low glycemic, it's more like 60 to 70% fat and you're allowed 40 to 60 grams of carbs, but they're low glycemic carbs. So carbs that don't increase your blood sugar much, like from berries or from an apple or those kind of sugars versus, a cupcake. For keto, we have to admit we usually do, Monday to Wednesday kind of admissions. Because you're switching over that metabolism so fast, and you can get really acidotic. So when you're burning fat, you get these ketones in your blood, and they're they're basically fatty acids. So when your blood gets too much acid in it, it can make you feel really crappy and nauseous. So we do it in the hospital knowing that that's going to happen at some point, and then we give a medicine to help buffer that. And so we check labs every 3 to 6 months. For keto, everyone needs that potassium citrate buffer to help with the acidosis, but we typically have to supplement with carnitine as well. And then for low glycemic, we often don't have to, but for anyone on diet, we typically supplement with multivitamin and calcium, vitamin D. For the low glycemic, the initial studies when they came out, about 1/3 either wasn't effective or tolerated. And then a third had about a 50 to 90% seizure reduction, and a third had 90% or more. And so that's pretty much what we see. With keto, it's probably a little bit higher, but what we generally do is for kids or either infants or have G tubes, we start with keto because it's just easy to do. For kids who are older and eating by mouth already, it's tough, so we just start with the glycemic, and then we can always convert it if we have to. And then the last thing is surgical options. So there's the vagus nerve stimulator has been around for a long time. I think we've talked about it a lot in the past. It's a little stimulator that you implant under the chest, just kind of under the skin, and it wraps around a big nerve that it kind of goes from the brain down to the organs in the chest and the abdomen, and the right one mostly goes down, the left one mostly goes up, so it's always around the left one, and it sends this electrical pulse up to the brain through the vagus nerve, and it. The exact mechanism isn't clear, but the way it works, but basically it kind of sends these pulses, and it disrupts the thought is that it kind of disrupts these networks that where the seizures originate. So if you can kind of disrupt that electrical activity, that you can hopefully prevent seizures from really forming. And the nice thing about this, you can swipe it with a magnet, and it sets off this minute-long higher pulse, which sometimes can actually stop a seizure once it starts. The basic kind of help, so that it's not meant to make you seizure free, but it can really, for 50% or more people, it can decrease seizures by 50%. So it's been helpful. Recently, deep brain stimulation, so kind of like what they do for Parkinson's, it's a stimulator that kind of goes right to the center of the brain, to those relay stations. We call it the thalamus. And so the vagus nerve stimulator, the VNS, it kind of travels up that nerve to the thalamus. This one, the deep brain, kind of does it directly, but as opposed to really using that much, what we've been using more is responsive neurostimulation, RNS, and we've been doing that a lot more the last couple of years. So what that is, it's a little stimulator that actually gets planted under the skull, and it has these electrodes that then attach right to the brain. And what it was meant for was, for surgery where you kind of resect part of the brain. People that have like just one spot in their temporal lobe, their frontal lobe, that's causing seizures. If you can cut that out, there's a good chance that you can make someone seizure free. With genetic syndromes like Dup15, like every brain cell has that abnormality, so you just start cutting lots of pieces out. But kind of similar to people that have those that one little spot. If it's in your motor area or your speech area, you don't want to cut out something that does things that are so important like that. So this was made to kind of go over those areas. and just to stimulate those spots that we know are causing the seizures, but we can't remove. But in kids with Dup15, what we would do is we would attach it right to the thalamus, so it would be that kind of responsive. It would instead of going up the nerve like the VNS, it just goes straight to the thalamus. But what's really kind of cool about the responsive neurostimulation is that it actually records EEG data, and it kind of continuously tracks it. And it actually gets trained to recognize the seizure patterns for that specific person that has it. And then when it sees a seizure pattern starting, it zaps. So it's not like the VNS is just kind of zapping all the time. You can make it go a little bigger when you see a seizure starting. Like this will actually kind of recognize a seizure, which could even be before you see it clinically, and then give the signal. So it's a pretty cool new surgical option that we didn't have a few years ago that we do now. So on top of the new medicines, this has also been a really a real nice kind of addition to what we have. And I think that's I didn't go over too far, I think, but so that was the update. We probably did take the whole time, but like I said, we have the clinical piece now, that the clinical question thing. So I'm sure we can take questions.
Absolutely.
Sure.
Can we just give him a round of applause? That was so fantastic.